Well, thank you very much for the opportunity and the invitation to talk to you. Just to give you some brief background of my clinical experience, I was the clinical director for the major drug treatment program in South Australia for 30 years. I left that position in 2016 to take up a university role for conducting more research with WHO. But in the time that I was the clinical director, I was responsible for both the Methadone treatment program and the Buprenorphine treatment program for opiate use disorders in South Australia. And I chaired the National Clinical Guidelines Committee. So I was the chairman of the committee that wrote the Australian clinical guidelines for both methadone and buprenorphine. So I come to you with some experience of both these medications as a clinician and as a scientist, because I've also been involved in the original studies in Australia that led to the registration of buprenorphine as a treatment for opioid dependence. What I want to do today is to talk to you about similarities and differences between methadone and buprenorphine for the treatment of opiate use disorders. And I'm particularly going to talk about it in terms of treatment of heroin dependence as a prototype for a short-acting opioid, because treatments for longer-acting opioids is slightly different. So I work in a pharmacology department now, and no pharmacology department would be seen as respectable without starting with some introduction to pharmacology. The brain has different receptors, which are where chemicals join into the brain. And the opioid receptors, the main one that we're going to talk about is the mu opioid receptor, because that's the one that causes the problems of dependence, but it's also the receptor that is responsible for the analgesic properties that opioids have and the euphoria. And regrettably, it's also responsible, the receptor that controls our rate of breathing. And that can be potentially a problem if you take too much opioids, and we know opioid overdose is usually leads to death by stopping breathing. What determines opioid effects is three basic principles. And this is, I do this now because there are major differences between methadone and buprenorphine, which are clinically very important. The first one is receptor affinity. That's how tightly the drug binds to the receptor. The stronger the affinity, the more difficult it is for other opiates to displace it from that receptor. The second is dissociation, how easily and quickly the opioid leaves the mu opioid receptor. And the third is the intrinsic activity. How much does the drug stimulate that receptor? Now, those three different dimensions are quite different for the opioids that we're going to talk about, and I'm going to talk about that in some detail. So, agonists, and methadone and buprenorphine are both agonists or antagonists, are acting at the same receptor but working in a completely different way. Methadone or heroin are prototypes of full agonists. They bind to the receptor and their effects are almost linear. So the greater the dose you give, the greater the physiological effect. Buprenorphine, however, has been typically called a partial agonist. It binds to the receptor, but it seems to have less intrinsic receptor activation. So it reaches a plateau in its effectiveness. And as you increase the dose, instead of increasing the effect, what you do is increase the duration of action. And I can see that somebody has unmuted their microphone, so it's causing background noise. Thank you for stopping that. And then we have an antagonist, naloxone, which is combined in Suboxone, we will talk about, but there are other antagonists, naltrexone and nalmorphine. These drugs bind to the opioid receptor, but they don't have any intrinsic biological activity. But because they're on the receptor, they can block the effects of other opioids by stopping them acting on that receptor. So diagrammatically, what you can see here is that these are the positive effects, and you can see as the dose goes up, there's potentially a lethal dose. And you can, for full agonists, exceed that so that the dose is so high that it actually stops the person breathing. But for buprenorphine, it acts as a partial agonist. And what happens is that the dose effectiveness plateaus. And as you increase the dose, you don't continue to get an increase in positive effects. And it doesn't reach a threshold where you would potentially reduce or stop breathing. And the antagonists like naltrexone, you can see they have no intrinsic activity. So the more you give, you don't actually see any positive or effects of the use of that drug. So while there are similarities between the full agonists like methadone and the partial agonists like buprenorphine, in that they have positive opioid effects, buprenorphine plateaus at a point below the point at which it would stop a person breathing. So the drug you're familiar with, methadone, and the drug that I'm talking about, buprenorphine, have three important things that need to occur to have an effective dose. It needs to stop withdrawal symptoms, reduce or eliminate the desire to continue using, cravings, and block the euphoric effects of any additional opioid that's being used, such as heroin. And we know that those three things need to be taken into account to find the most effective dose. We also know that the longer you're in treatment, the better the gains. So both methadone and buprenorphine treatment should be measured as a longer-term treatment, usually measured in years rather than days or weeks. And we know that both of these treatments substantially reduce, but they don't always eliminate on-top heroin use. And some of our patients continue to use occasionally, but nowhere near the levels they were using before they entered into treatment. We also know that they protect against bloodborne viruses, especially HIV and hepatitis C, reducing the risk of overdose death and reducing criminal behaviour. The mechanisms by which they reduce the risk of overdose death, though, is different, and I will come back and talk about that later. So there are advantages of treatment, and all of these things would be already familiar to you in terms of the benefits that occur, and those benefits hold true for both methadone and buprenorphine. And we know that treatment is more effective if it's combined with psychosocial support. So if you look at the drug that you're familiar with, methadone, it has good oral bioavailability, which means that it's taken by swallowing it. And the peak concentration occurs about 2 to 4 hours after a dose. The vast majority of it's protein bound, which means that it has a long half-life, around 24 hours. but it takes some time to get to a stable dose. It takes between 3 and 10 days. Because of that long half-life, it takes a longer period of time for it to stabilize. It's complicated in its metabolism in that the majority of it is moderated through CYP3A4, but you can see there are a variety of other cytochrome-mediated enzymes that also metabolize methadone. Now, that has two important implications. One is that there's a genetic variability in the rates of metabolism, and you may have seen some people who rapidly metabolize methadone, and as a consequence of that, the duration of 24 hours doesn't quite hold them. The other implication of it is that a lot of the medicines that you might also need to prescribe, particularly HIV medications, but also other common medications, are often metabolized in these other cytochromes. And so there's a risk of drug interaction that they might either increase the plasma concentration of methadone or decrease it. And so you need to be careful about that and take that into account. And I'm sure that you're already familiar with everything that I've just said, but it's important that you remember that when you're starting to compare it to the effects of buprenorphine. So just to reinforce the effect that I was talking about, you can see on a single dose of methadone, it reaches a peak concentration, but then on day 2 and day 3, even giving the same dose, the plasma concentration increases because it takes between 3 and 5 days to reach a stable plasma level, even though you're giving the same dose. But once you have achieved a stable dose, it then means that it stays that way. So after 3 to 5 days, the interdose interval of 24 hours, you can see the difference between the peak and the trough. The individual doesn't feel that difference, and so they feel as if they are on a stable dose. But for the first 3 to 5 days, the same dose is having an increasing effect on a daily basis. That is quite different to the way buprenorphine works. Okay, so there are some limitations of methadone treatment. It requires daily supervised dosing. The highest risk of overdose death from methadone intoxication, of getting too much methadone, is in the first 1 to 2 weeks, because often people are feeling that the dose is inadequate, and if the prescriber isn't familiar with that fact that the same dose increases the plasma concentration each day, there's a risk of increasing the dose too quickly, and hence the risk of overdose. We also know that it interacts with other central nervous system depressants, such as benzodiazepines, which also increase that risk. The way that methadone blocks on-top use is by increasing your tolerance to the effects of opioids. So what you're doing is that you are greatly increasing the tolerance the individual has, so that if they use additional opioids, they don't get any additional effect. It doesn't work by occupying receptors, the mu opioid receptors. It works by changing the level of tolerance that you have to opioids. And I've already mentioned through the cytochrome and genetic activity, there is a great variability. In my clinical experience, we used to have somewhere between 1% and 5% that we would see as rapid metabolizers, and that those people would need to have more than once daily dosing for methadone, that we could not give them a sufficient dose that they would be able to go 24 hours. And of course, with methadone, we've also seen the risk of diversion of it and being used in a way in which it wasn't intended. So there are some limitations. Buprenorphine is a drug that's been around for some time. It was developed in the 1970s, initially prescribed as a drug called Temgesic, and it was registered as an analgesic, was typically used in anesthetic practice. But then for the treatment of heroin users, it started to be used in the mid-1980s and early 1990s, which led to its registration as a treatment for opioid dependence. It was first registered in France in 1995, and I was asked by the Australian government to go and look at the French system. And after we had conducted studies in Australia, it was first registered in Australia in the year 2000. We quickly transferred from Subutex to Suboxone, which is the combination product of buprenorphine with naloxone. Initially, the tablets in 2003, but we moved over to the film in 2012. And the reason we changed over to the film was because we were having some problems with people diverting the Suboxone sublingual tablet, and the film is much more difficult to divert. And I can talk about that in more detail if you have questions at the end of the presentation. It's now been approved in over 40 countries throughout the world. And in 2019, depot formulations, this is injectable formulations, were introduced, and I can talk a bit about those as well. So buprenorphine is quite different to methadone. It is rapidly metabolized in the liver by first-pass metabolism. So it's not a drug that you can swallow. But if you stick it under your tongue, it gets rapidly absorbed into the bloodstream and hence bypasses the liver. And so it's able to reach therapeutic doses. And of course, it's also able to be given parenterally, that's by injection. And that's the reason why these slow-acting preparations also work that way. The second major difference is metabolism and excretion. This is a drug which is virtually solely metabolized by the CYP3A4, which is the main enzyme that metabolizes methadone. But as I said, there's a bunch of other CYP and cytochrome enzymes that also metabolize it. So there's less drug-drug interactions with buprenorphine, but there are a few, and I will talk about them in a little while. But it's less complicated to use because of that, and it has a different route of administration. You need to provide it sublingually. You can't use it orally. It's a partial receptor, mu opioid receptor, which means that it has a ceiling effect with increasing doses. And what happens is if you increase the dose further, it doesn't increase its potency, it just increases its duration of action. It has a very high affinity for the mu receptor, much higher than methadone. So if you give it to a person who's taking methadone, it will actually push the methadone off the receptor and replace it. So it's highly competitive and it has very strong binding characteristics. Its onset's a little bit quicker. It starts to work within 30 minutes and its peak action is at about 1 to 2 hours. And because of its slow dissociation, so it slowly goes off the receptor, it actually has a very long duration of action, which is dose dependent. It's quite a safe drug to use. it's easier to use than methadone, both in the single dosing as well as maintenance treatment. Like other mu agonists, it causes similar side effects, nausea and constipation, but they appear to be less severe. There's no evidence that it affects your thinking or your psychomotor performance. And in fact, some patients say they complain about that if they've been on methadone treatment before, because they don't have the methadone fog that is commonly reported amongst people who've been in methadone treatment on higher doses. They tend to say that life is bright, it's very clear, and some people don't like that. They find that distressing. There's no evidence that it causes any organ damage from chronic dosing, so it doesn't cause any long-term damage to any body organs. The duration of effect really is dose dependent. So when we first started using buprenorphine, we were cautious and a bit scared of it. We didn't have much experience with it. And so we tended to treat it like we treated methadone, that start low and slowly increase. And we actually found that's the wrong way to do it. With buprenorphine, you have to wait until you see signs of opioid withdrawal. If you do that, then it will rapidly bind to the opioid receptor and it won't precipitate withdrawal. It won't throw other opioids off, but then you can rapidly escalate the dose. And for moderate dose, which are 8 milligrams or above, it lasts 24 hours. But for higher doses, 16 milligrams or greater, it will actually last 2 to 3 days. You get steady state equilibrium after 3 days, and we intend to have the person on their maintenance dose by day 3, which again is a very different approach to the way you would approach that slow, gentle increase of methadone dose, because you're trying with methadone to increase tolerance. But with buprenorphine, what you're trying to do is to occupy mu receptors. Even though we call it a partial agonist, it is a potent analgesic, and it's probably as potent as morphine. And so doses up to 11 milligrams, you get equal potency of in terms of pain relief. And it does work to hold people who have high addiction, so people who've been using a lot of heroin, as well as people who have been using smaller amounts. So you don't need to use it as a consideration that it's only for people with moderate dependence. It works equally effective for people who are very addicted to heroin. You're also able to successfully transfer people from very high doses of methadone. I know in Thailand, you would nowhere ever use doses of those kind of levels, but it's possible to transfer. It's just something that we would normally reduce the doses down to 30 to 40 milligrams before we would transfer over to buprenorphine. The main ceiling effect that we talk about is on respiration, blood pressure, and heart rate. There appears to be a bell-shaped dose response curve that as you increase the dose, you get a maximum depression of respiration, but then as the dose increases, it seems to have less of an effect. So it's very safe in terms of the risk of respiratory depression. This is showing you the way that buprenorphine works, which is quite different to methadone. You can see on these MRI scans the opioid receptors shown here in green and high density in red. And you can see at 2 milligrams, you're starting to see receptor occupancy, but by 16 milligrams, you've virtually covered all of the opioid receptors, and certainly at 32 milligrams, which is the maximum dose that you're allowed to prescribe in Australia, you've got complete blockade. But for all intents and purposes, once you've gone above 16 milligrams, what you're doing is increasing duration of action. You're not increasing the potency of its effect. At 16 milligrams, you've virtually got full mu opioid receptor occupation. And you can see that when people have been given hydromorphone as test doses to test the effectiveness in terms of user liking of that drug, well, how did they feel? At low doses, when we have 6 or 8 to 18 milligrams of hydromorphone, you can see that there was an increase in the enjoyment that they got from having that full agonist. But when we get up to 8 milligrams and 16 milligrams, the enjoyment has been virtually extinguished. So there was a temptation initially with buprenorphine to try to use doses as low as 4 milligrams. But we now, in Australia, a typical dose of buprenorphine would be 12 milligrams per day. And we usually aim to be in that 12 to 16 milligram group. Some people are managed on 8, but we would rarely go less than 8 milligrams as a maintenance dose. This is also highlighting that point I made before, that even at doses of 32 milligrams of buprenorphine, we still have an acceptable respiratory rate of 12 breaths per minute. So even at high doses, while it does appear to reduce respiratory drive as we get into 4 milligrams and above, it doesn't have the same risk profile that methadone does, that if you increase the dose too quickly, you could actually stop people from breathing. Okay, so just summing up a few things here. It has a slow receptor dissociation, so it takes a lot longer to get off the mu opioid receptor, which means it has a longer duration of action, and potentially the severity of withdrawal is less severe. When we were first starting to use buprenorphine, we wondered whether that would mean that people would just drop out of treatment. We haven't found that to be the case. And in fact, now we talk about the 2 milligram syndrome, that when people get down to doses of 2 milligrams, they start to feel withdrawal and they don't like that feeling. And so we've used tapering doses to try and help them get off, the same as you do with methadone. So I don't want to overstate that modal withdrawal, nor do I want to overstate the physical dependence liability. It works by a different mechanism, so you're not radically increasing their tolerance, but by receptor occupation, you block the effect of full agonist use. So if you're using adequate doses, they don't get the euphoria from on-top heroin use, because the binding characteristics of buprenorphine prevent the heroin from accessing that mu receptor. And I've talked about the ceiling effect on respiration, and you have to use it sublingually. It will not work orally. Now, we've combined, and the medication that you'll probably be using is with naloxone, which is an antagonist. And you may be wondering, so why would you combine an antagonist with a partial agonist? Well, it's inactive if you take it orally and poorly available sublingually. But if you inject it, it will precipitate withdrawal in people who are dependent on opioids. So the idea is to encourage sublingual use and to discourage intravenous use. So the reason this has been added is to prevent injection of the sublingual preparation. And the naloxone, it doesn't really compromise absorption of the buprenorphine. The buprenorphine dose is the same whether you give just straight buprenorphine or the buprenorphine combined with naloxone. It doesn't interfere with the onset or the peak action. So it's only really there to prevent injection. It doesn't have any pharmacological activity unless you use the medication in the way in which it wasn't intended. And the dose ratio of 4:1 was determined by trying different ratios until they found the one that caused the most deterrence effect by injection. Okay, so this is just saying that there was no real difference between the two, and naloxone gains rapid access to the receptors and will precipitate withdrawal on people who are heroin dependent or methadone dependent if they take it by injection, and that effect lasts for about 2 hours. So the injection of the combination product will precipitate withdrawal in those who are dependent on full agonist opioids. And I think I've already spoken to that, and I've talked about the reason why the combination is the best. So this sums up what I've just said, and I'll just run you through these, comparing the two products. So if you're heroin dependent and you take buprenorphine on top of the heroin, the buprenorphine will displace the heroin and might cause a mild withdrawal, but it is something that is usually tolerable. But if you inject the combination buprenorphine naloxone product, it causes a precipitated withdrawal. For somebody who's non-dependent, so they were able to access either the buprenorphine mono product or the combination product, they would get a mild agonist effect if they injected it. Attenuated, they would get a slightly lowered effect because the naloxone would be competing with the buprenorphine. For the heroin, the methadone maintained person, they would get an antagonist effect. So if you take buprenorphine by injection and you're on a maintenance methadone dose, the buprenorphine will push the methadone off the receptor, and it has less intrinsic activity on that receptor than methadone. So it has higher receptor affinity, but lower intrinsic activity, and hence you would cause withdrawal because you're not having the same full opioid effect. Okay, so buprenorphine naloxone, the combination product, is well tolerated, doesn't appear to have adverse effects if you use the naloxone. There are no safety concerns of administration, and it doesn't appear to interfere with the buprenorphine absorption. But because of continued, can I just get whoever's talking to mute their microphone, please? We don't use the combination product in pregnancy. That's the one time we don't use it, because the safety of long-term exposure to naloxone has not been proven. So for pregnant women who were on the combination product in Australia, we transfer them over to the mono buprenorphine product during pregnancy. Okay, and I've covered all those points. Side effects are very similar to what you would expect for methadone. And of course, there are expectancy factors that people expect to get side effects. And so we often get over-reporting unless we reassure them that most of these side effects slow down. There are some differences to buprenorphine. Headache typically happens in the first few weeks, but settles down and doesn't happen with everybody. All of these other effects are typically seen in methadone as well, and they are no different. The drug interactions that I mentioned before, it can cause respiratory depression if they are taking high-dose benzodiazepines, and you need to be careful with other drugs that also are metabolized through CYP3A4, so protease inhibitors, ketoconazole, nifedipine, and some of the antiviral medication are also likely to cause a drug interaction. But this list is much shorter than the list you would expect to see on methadone. So, all drugs have abuse potential. It's less likely to occur with the combination product than the mono product because of the effect that I showed you of either precipitating withdrawal if you are already opioid dependent, or an attenuated effect if you are not opioid dependent. But the French found who do not use the combination product, they use the mono product, but even so, there was greater safety. The ratio of deaths per patient was 10 times less with buprenorphine than with methadone. So the experience in France was, even with just having the mono product, the risk of death was much lower. So maintenance treatment, we've talked about the fact that it's got high affinity, which means that it can precipitate withdrawal. So if you are opioid dependent, then the timing of the first dose is critically important. And what we do is we wait for mild level onset of withdrawal before we give the first dose of buprenorphine. If you do that, the buprenorphine is taken up by the free receptors and the patient feels better, and then you can rapidly increase the dose after that. Generally, precipitated withdrawal commences somewhere between 30 minutes and an hour and a half after the first dose, and it peaks somewhere between an hour and a half and 3 hours after that first dose, which is completely different to an inadequate dose, which typically occurs much later on. So this is probably one of the things that clinicians need to get used to when they're using buprenorphine. But if you delay that first dose until there's mild withdrawal, in Australia, we use the clinical opioid withdrawal scale, the COWS score, and we wait for early onset withdrawal where we'll see a COWS score of 6 to 8, and we would then give them 4 milligrams. And if they tolerate that, after another hour, we would give them a further 4 milligrams. So they would be on 8 milligrams of buprenorphine on the first day, with an intention of getting them to 12 to 16 milligrams by day 3. So we rapidly increase the dose, which is completely different to the way you would treat them with methadone. So you can see precipitated withdrawal typically occurs very early on, and that means you've given the dose of buprenorphine too early. How do you manage that? Well, we manage it by giving more buprenorphine. So we swamp the buprenorphine receptor, the new opioid receptors, to quickly get on top of it. It's quite different to an inadequate dose that you see at 24 hours. People are starting to report severity of opioid withdrawal. These are COW scores. You can see that it is a much longer process before it gets on. So the early studies, as I say, they were very cautious. They used methadone induction protocols, very high dropouts in the first 2 weeks because people were being underdosed. And that means that we have changed our approach. We typically would aim to be somewhere between 6 and 8 milligrams on the first day, and we typically would be wanting to be 12 to 16 milligrams by day 3. And these old schedules are wrong. The way they approached it was completely wrong. It was too cautious. You have to just wait until you see signs of withdrawal and then aggressively increase the dose. I've talked about this before, but I want to really accentuate this point. Some people become quite anxious because they suddenly feel very clear-headed. Instead of that stone feeling of being on heroin or that methadone buzz that people talk about, that they feel a bit sluggish in the head, buprenorphine doesn't cause that, and people get anxious about that. There can also be concerns about withdrawal, so you need to talk people through that. So I'm sorry, somebody was speaking there. Was that saying to me we're running out of time? Because I think we are. Apanand, do I have time to continue a bit more, or would you like me to stop there? I do have time? Okay. So we aim for 16 milligrams. That's got full receptor occupancy, is the most likely dose to stop the effects of on-top use. It will stop withdrawal, and it will stop or significantly reduce desire to use, the cravings, but it's done with a clear head. If you go beyond 16 milligrams, you've already fully occupied the receptors. What you can then do is to think about alternate day dosing or 3 times a week dosing. And so we again were too slow in our thinking about that. If you're going to go for alternate day or 3 times a week dosing, you should be starting that after 2 weeks on a maintenance dose of buprenorphine. We tended to wait too long. People got used to the idea of daily dosing, and then it was very hard to shift them over to alternate day dosing because they were scared that it wouldn't hold them. But actually, after 16 milligrams, the duration of effect is pushed out to 2 to 3 days. So, key principles: first dose delayed until they're withdrawing. We measure it using the COW score. We don't normally get precipitated withdrawal if they're on heroin. The greater risk is with transfer from methadone, and there you really do need to wait several days until you start to see, particularly people who've been on higher doses, you start to see objective signs of withdrawal. After you review the side effects and if you've talked to them about that, if there's signs of withdrawal, you give them more buprenorphine. If there's signs of intoxication, we also see in the first few days, people often confuse the situation by continuing to use a little bit of heroin as well. We warn them against that because it will actually interfere with the stabilization process and may precipitate withdrawal as well. The alternate day dosing, I've talked about this, greater than 16 milligrams, you get little or additional effect, so you can stabilize usually for 2 weeks, and then you can then try 3 times a week or alternate day dosing. Particularly for your populations that have long distances to come to clinics for supervised dosing, this is a godsend, because it means that they don't need to be treated on a daily basis. Normally, dose period is double the daily dose, and we, as I said, we're capped at a maximum of 32 milligrams. You can review it after the first or the second period and adjust if you need it. If it's 3 times a week dosing you want to move to, we try that after 2 weeks. So we try 2 weeks of alternate day dosing. If they tolerate that, we will then go to 3 times a week dosing and see if they tolerate that. It really is dependent upon the amount that they're taking, but it can be done with as little as 12 milligrams. So, new innovations. We now have two different companies making injectable buprenorphine. Indivior, their product's called Sublocade. That's a once-a-month injection. And Camarus has a product called Buvidal, which allows either weekly or monthly injecting. The reason that they introduced the weekly formulation was for people that you were concerned about their stability. It meant you could observe them in the clinic more frequently, so you could see them on a weekly basis. Our clinic was involved in both Sublocade and Buvidal trials, and actually we found most patients settled on the monthly dose and did not present a problem. So the people that we initially moved on to these injectable formulations were people who'd been on buprenorphine for some time and were stable, but we are now also introducing it clinically that they would be inducted and stabilized on sublingual buprenorphine and then transferred over to the injectable product. And it is done by monthly rotation of the injection into the abdomen. So I just wanted to finish by comparing and contrasting methadone and buprenorphine. Methadone, a drug that you're already very familiar with, suppresses opioid withdrawal. It's done orally. You need to take it daily. You've got to be very slow in taking people off, otherwise you cause withdrawal. It's best done with counseling. It's legal, so they don't have problems with crime. And it's either free or low cost. There are some problems with methadone, though, and you would have experienced this, that gentle increase in dose so that you increase the neuroadaptation or the tolerance they have to opioids takes time. And so there's discomfort in the stabilization phase. They're opioid dependent because you have increased their opioid tolerance above the level of their tolerance on the heroin that they were addicted to. It has to be negotiated to wean them off over a long period of time, and the withdrawal symptoms from methadone treatment extend a long time after they stop their methadone treatment, which can lead to relapse back into opioid use. And because it's a full agonist, if they take other drugs on top, there's a greater risk of overdose and death. And of course, you have to come to the clinic to have the medication. So that can represent a problem. Buprenorphine it's very easy to use. It's the preferred medication that's used by our primary healthcare doctors who aren't specialists in addiction treatment, because the transition into from heroin is easy and can be done as an outpatient. There's a very wide safety margin. You give them an initial dose of 4 milligrams. If they tolerate that, you give them another 4 milligrams. They are not likely to be suffering from withdrawal, but we know you need to get them up to between 12 and 16 milligrams for the best effectiveness in terms of a receptor blockade, and you should have done that by day 3. So it's a much smoother, quicker process. The withdrawal that they get when they stop isn't as intense, but we do have people complaining when they're wanting to stop from 2 milligrams, and we've been experimenting with slower rates of withdrawal from 2 milligrams down. It's more convenient that you can do alternate day dosing or 3 times a week. It works by receptor blockade, not by increasing tolerance. So we find it's more predictable and easier to taper off. The tablet under the tongue is easier to divert than the film. The film sticks to the tongue, and after 30 seconds, it's virtually impossible to take off. The tablet, we need to keep the people in the clinic and supervise them until the tablet has been absorbed, and that takes time. The way we speed that up is to crush the tablet. So we use a pill crusher. You might use that in your geriatric population to help them swallow. You crush it, they put that under the tongue, and that increases the speed that it is absorbed into the bloodstream. And we can't use the combination product in pregnancy. We have to use the mono product. So this is the most recent Cochrane review, and you can see in terms of likelihood to use heroin, self-reported heroin, cocaine use, benzodiazepine use, criminal activity, there is no statistical difference. There is a statistical difference in retention in treatment, which benefits methadone, but that is not true in the open label studies. So our belief is, and I know this to be true, that the 5 studies that are drawing it towards a statistical difference in terms of retention were all studies where there was slow induction stabilization rates. And if you do that rapid 3-day induction, you won't have the same dropout problems that occurred in those earlier studies where people were being very cautious. How do you choose which treatment? There's no clear scientific way of differentiating it. We tend to try buprenorphine, and if they're not successful on buprenorphine, then we move them to methadone. For people on methadone who are becoming risky because of either concurrent alcohol or benzodiazepine use, we tend to shift those people to buprenorphine. It really is the logistics of treatment and how they respond. Some clients want buprenorphine, some clients prefer methadone. We don't stand in the road of that if there's a clear client preference. The ability to transfer, it's a lot easier to transfer from buprenorphine to methadone than it is from methadone to buprenorphine. For buprenorphine to methadone transfer, very simple process. For methadone, you have to reduce the dose down to between 30 and 40 milligrams, wait till there's objective signs of withdrawal, and then start on that induction regime. It's a little bit more tricky, but it's not impossible. And that's the end of what I wanted to